Good afternoon. Thank you all for coming to the Markou seminar series. I'm very excited and delighted to introduce my colleague and friend, Dr. Kipling Bohnert. Kip, as we know him, is an assistant professor in the Department of Psychiatry, University of Michigan Medical School. He's also a research investigator in the Department of Veteran Affairs, VA Ann Arbor Healthcare System, the Center for Clinical Management Research, which is part of the Health Services Research and Development Service there. It's the Center of Excellence. He has a background in public health from Johns Hopkins University and a PhD in epidemiology from Michigan State University. His research seeks to better understand causes and consequences of substance use disorders, and mental health disorders, and also helps address gaps in care for individuals with such conditions. He has a Career Development Award, a VA Career Development Award, and it's entitled VA Healthcare Delivery for Returning Veterans with Mental Health and Substance Use Disorders. And it really aims to understand mental health and substance use services delivery following mandatory screening that returning veterans undergo, and to improve the healthcare delivery as well as their engagement in that care delivery of veterans who are identified via that screening. He's also PI on a VA Merit Award, which is an R01 equivalent, that's studying patterns of regular cannabis use and health functioning and service utilization among VA primary care patients. So today he's going to talk about recent findings regarding medical cannabis patients from community to the clinic. Welcome.
All right, thank you. Thanks, Brian. Thank you, everyone. Thanks for attending my talk today, and thanks for coming on a 4 o'clock on a Monday afternoon. I think it's Monday. I can't remember. So just before I begin, I wanted to thank Brian again, as well as Dr. Grant and others for inviting me to speak today. I'd also like to thank the Markou seminar series for being able to talk. I'm got a chance to read a little bit about Dr. Markou and was really impressed with her research, as well as just the impressive human that she was, and I'm honored to be speaking today at this event named in her honor.
I just wanted to say that unfortunately some of our cannabis people are at the CPDD meetings, so I apologize for that.
Oh, no worries. I actually said, I'll connect with them, I'm sure, at CPDD as well, so okay. It'll all work out. So
here we got. Well, believe it or not, this is one of our faculty. we're a very cool department.
Yes, seems like it. That's great. Hi. So before I begin, I also like to just here are my disclosures. I am in psychiatry at the University of Michigan, as well as at the VA Center for Clinical Management Research. And I'm funded by VHS R&D, and I have no conflicts of interest to report. So I'm just going to give a brief overview of what I'll talk about today. I'll give a little bit of context of medical cannabis use in the U.S. from a kind of a population perspective, and I'm sure most of you all know that already, but it'll be a nice refresher, maybe. And then I'll talk a little bit about 2 projects from the NIDA R01 that I've been working on with Mark Ilgen, and I'll also talk about my VA IAR, which is really starting up right now. Then I'll give a brief discussion and future directions for research. So as most of you know, cannabis is the most commonly used drug outside of alcohol and tobacco in the United States. Around 14% are past year users in the U.S. based on recent estimates from the National Survey on Drug Use and Health, and 37 million, that's around 37 million folks with past year use. And with respect to trends, There's been an increasing trend since 2002 in past year use. This is especially the case in those aged 26 years and older, and it's not the case in the adolescents where there's been a little bit of a decrease actually, and this is against the backdrop of increasing norms and attitudes about cannabis use, including risk and availability, risk being less risky as the years have decreased in terms of perceived risk. With respect to kind of more broader context of state level, there's obviously geographic and variation with respect to cannabis use. Those in Michigan, my home state, and California, for example, are kind of more, there's a higher percentage of past year users versus states in the South, for example. And then, as most of you know, I'm speaking to the choir here just because I've talked with Igor just recently about medical cannabis, and 29 states obviously have legal cannabis. 9 states have legal recreational cannabis, and these states are also similar to the states that are in this previous slide that are using higher levels of cannabis too. So that's also coincidental. So with respect to medical cannabis in the U.S., one of the studies that in 2013, the National Survey on Drug Use and Health began ascertaining medical cannabis use or cannabis use recommended by a physician, and we used that data to kind of provide the first snapshot of medical cannabis use across the U.S. in the general population. And this study was published in 2016 in Addictive Behaviors, and we found that among past year cannabis users, around 17% said they had any medical cannabis use. And with respect to comparisons between medical users and those who didn't use or medically or used recreationally, they were relatively similar in terms of the population of the characteristics of those individuals. However, those, not surprisingly, those who used medically had worse health and were more frequent users, more daily users in that category. So that roughly equivalent to around 2.8 million users in the United States in any given year are medical cannabis users. From some of our work and others, chronic pain is one common factor for medical or qualifying condition for medical cannabis certification. Obviously, that varies by state. Here in California, there are a lot looser regulations in terms of qualifying conditions compared with Michigan. We are more tightly controlled with respect to the number of qualifying conditions, and that also varies state to state. But most states have chronic pain as an allowable condition for medical cannabis use. So this kind of provides a backdrop. What I'm going to talk about today kind of is more related to clinical epidemiology, and in particular, there's a focus and a need for better understanding of whether measures and constructs developed for recreational use really are appropriate for medical use setting. And then I'm also going to talk a little bit about how medical cannabis use relates to other medical conditions and treatments, pain and opioid use, functioning, and health services utilization, especially from a health systems perspective, since I also work in the VA as well as the university setting. So the first 2 projects that I'm going to talk about are from Mark Ilgen's, they come from Mark Ilgen's R01, Medical Marijuana Longitudinal Trajectories in Use and Pain. And so just to kind of give a brief background, just as a disclaimer, this is not the cannabis clinic that he collects data from, so please do not call this number. Actually, I should have, anyway, the screening, so there's a screening component and a cohort and follow-up component to this study. And in the screening component, we selected cannabis clinics throughout the southern part of Michigan to screen the patients coming forward for certification. And we, with the aim of having a cohort of 800 folks who use cannabis for pain. And there was a threshold of you had to have average weekly pain of 5 or of a pain level of 5 or more in this cohort. And this cohort was then followed for 2 years and followed for every 6 months for 2 years. And they had follow-up rates of 85 to 89%, which is, as you know, for a cohort study is pretty impressive, and kudos to the research staff for all of their hard work, because this was a study that was conducted throughout Michigan, and some of them literally had thousands of miles on their car at the end of the study. And so I'm happy to kind of talk a little bit more about this project. So the first project that I'm going to talk about is something that I was really interested in, and it utilizes this was before the cohort data was all complete, and so I wanted to really kind of focus on some of the measurement issues with the medical motivations for use and motivations for use in general. Mark, and this is a paper that we recently published, entitled "The Utility of the Comprehensive Marijuana Motives Questionnaire Among Medical Cannabis Patients." So, as many of you know, in addition to using cannabis to manage medical complaints, adults who use medically also do so for other reasons, including coping, boredom, stress, relaxation, and enjoyment. And so in addition, early work on motivational models were really focused on alcohol use, and they were subsequently adapted to cannabis use. Christine Lee and colleagues then took some of these models and developed the more extensive measure of cannabis use motives, the Comprehensive Marijuana Motives Questionnaire. And this was done in 2007 and 2009, and it was done with a sample of relatively low frequency, infrequent cannabis users in the college setting. So it's really questionable whether this generalizes to other settings and whether the measure can be used in other settings. So another kind of important point is that previously certain motivations for use were associated with negative consequences and problematic use, and whether this is the case in the medical cannabis kind of community is unknown. The other interesting thing is that there also motivations have been shown to be mechanisms of change with respect to interventions. For example, they've been shown to change following cannabis-focused intervention, and changes in motives are associated with those intervention outcomes. So they may be important to inform harm reduction strategies in this population if they're warranted. So again, the aims of this study were really to examine the performance and utility of the CMMQ, the Comprehensive Marijuana Motives Questionnaire, among medical cannabis patients. And we had both a kind of a methodologic and substantive aim. The methodologic aim was obviously to look at the psychometric properties and things like that, but we also were wanting to look at the endorsement of various motives and see how that looked in this population compared to, for example, the college-age population where it was developed. And then, so we also looked at relations between motives and frequency of cannabis use and physical and mental health functioning. So just a kind of a brief demographic snapshot of the screening sample. This is kind of typical of some of the medical cannabis samples that you've probably seen were predominantly white, predominantly middle-aged, and predominantly male. And this was the case in our sample, and is also the case in the cohort. So with respect to cannabis use characteristics, most were seeking for severe and chronic pain reasons, with less seeking for other reasons. And around 70% were current cannabis card holders. The frequency of cannabis use was around 72 days in the past 90, and there was a low physical functioning and a relatively low mental functioning group. So the physical functioning was about a standard deviation and a half below what the general population is, which is typical of potentially pain patients. So with respect to the confirmatory factor analysis, you can see here the internal consistencies and the factor loadings. And what's kind of remarkable is that both the factor loadings and the internal consistencies are really, if you look at the Lee paper and if you look at recent work by Claire Blevins, they're pretty similar with respect to the factor loadings. And it also indicated this acceptable fit. The other thing that I would say is that the internal consistencies are a little bit better for altered perception, celebration, compared to conformity and some of the other, mainly conformity motives. So this shows kind of the level of endorsement of the marijuana motives, and the marijuana motives are a Likert scale from 1 to 5. You can see here that some of the motives are relatively low. There's relatively low endorsement, and some of them, like sleep, for example, and enjoyment, are more highly endorsed. And so that's a difference between this population and the college-age population. With respect to, we then did a kind of, we did a regression looking at which motives kind of are associated with cannabis use, controlling for all the other motives. And you can see here that enjoyment and sleep are associated with greater use, excuse me, whereas experimentation and altered perceptions are associated with lower use. Excuse me.
Take a break for
Sorry.
a second. Yeah. Been there, done that. Do you need a tissue?
No, I'm fine.
Psychiatry department always has tissues. Take a minute.
Thanks.
Clear it. Don't worry about it. And do you have enough water there?
Yeah, I have some down here.
Okay, great.
I'm sorry, I'm getting over a cold. Sorry, back to square one.
This thing doesn't have obviously the reduction of pain as a potential motive,
Right, and that's something that I was going to talk about in kind of the discussion point. So these were the motives that were associated with physical functioning. You can see that coping, boredom were associated with more higher physical functioning. Sleep was associated with lower physical functioning. With respect to mental health functioning, you can see that enjoyment and celebration were actually associated with greater mental health functioning, but coping, social anxiety, and sleep were associated with lower mental health functioning. So this study provides novel information regarding motives for cannabis use among adults using medically. Again, the factual ratings were relatively similar to the Lee et al. Study and also the Blevins study, which is kind of interesting and not necessarily what we were expecting to find. And it really lends support for the utility of the CMMQ among medical cannabis patients. So we can use this tool to assess motivations potentially in the medical cannabis patient population. But again, to Brian's point, adaptation of the scale to include assessment of medical motives for use, including pain, may be warranted. Excuse me. The other thing is that we could trim conformity, and there would probably be better fit. So again, individuals using cannabis for medical purposes appear to have diverse reasons for use, and it's important to extend these findings longitudinally. Obviously, this is cross-sectional. Those are associations. And so we need to look at this long-term and what are these the long-term associations with some of these motivations, especially with sleep and some of the coping motivations that may be important. Thanks again. The other thing that's, I think, interesting to think about is what are the longer-term outcomes associated with enjoyment and celebration. Obviously, we're showing that those are associated with more positive physical and mental health functioning. Is there some potential beneficial thing going on with enjoyment and celebration? And the other thing is, how do these changes in motivations relate to health over time? Because one day you can use for sleep, and the next day you can use for enhancement or boredom or something else. And in particular, Aaron Bohnert, one of my colleagues, has done some really interesting work looking at daily associations between motivations and subsequent use. And so there's a real dynamic process in here that's going on. But the point of this study really is to show that we can use this measure probably in the medical cannabis community. The other thing to think about is, can we incorporate some of these measures in risk prediction tools? So a little bit different than just explaining the phenomenology, but kind of predicting who or who won't respond to certain interventions. So I'm going to pause for a second and take a swig.
Yeah, take your time, really. We don't want to torture you here.
So the second project that I'm going to talk about today is kind of hot off the press longitudinal data from Mark's medical marijuana study. And this is using the cohort of pain patients that have been followed up for 2 years. So most of you have kind of read the studies that have looked at medical cannabis laws and opioid overdose and other opioid related consequences, and finding that medical cannabis laws perhaps reduce opioid analgesic overdose. These are all based on ecologic data, all at the population level, and there really have been few individual level studies that have examined this risk over time. And so we thought, well, we have a group of patients who are getting medical cannabis for pain conditions. Let's look at their opioid misuse over time, as well as their use of cannabis over time. So in this this is a kind of a preliminary investigation. We just had the data cleaned a few weeks ago, and this is hot off the presses. We examined latent trajectories of risky opioid use over time among medical cannabis patients. We compared these trajectory groups by kind of the frequency of use. Obviously, we can do some more things. We're going to be modeling some more things later on, but this is kind of an initial glimpse at what's going on. So for the opioid misuse or risky opioid use was assessed using the current opioid misuse measure. Many of you who have studied pain probably also use the COM in some of your work. Briefly, you can see that it measures opioid misuse in the past 30 days on a Likert scale. How often have you taken your prescription pain pills differently than prescribed, for example? And just a bit more on latent trajectory analysis. So latent trajectory analysis is a method that identifies clusters of individuals in a population with similar progressions of an outcome over time. So we think that in what's going on in the background is that there are these heterogeneous groups that have similar kind of trajectories, and this allows us to use the observed data that we have to find to identify these trajectories. And it's we use ProcTraj, which was developed by Nagin and colleagues, and so feel free to. It's widely available in SAS to use it. So this is we found 4 latent trajectories of opioid misuse in this population, or in our sample rather. And you can see the red represents stable no misuse. The green is relatively low misuse to start, but it decreases over time. The blue is stable, kind of low misuse, and the black is stable, kind of modest misuse. No one's really kind of misusing opioids at a really high level in this patient sample. Most are actually at relatively low risk. And then we looked at kind of some of the characteristics of the 4 latent trajectories. These are kind of the basic characteristics of age, gender, race, and whether or not they sought cannabis, were seeking cannabis for the first time, which I think is relatively interesting because in the green and the black group have larger percentages of folks who are seeking cannabis for the first time. And there are some differences by gender as well in the different groups. So this is not a latent trajectory of cannabis use, but this is the actual observed cannabis use in the different latent trajectories of the latent trajectories of opioid misuse. So here you can see this is the stable no misuse opioid misuse. They actually have the highest percentage of daily, almost daily cannabis use across the 24 months. The folks in the green decreasing misuse group actually are the percentage of those who are using daily or near daily is increasing over time, which we didn't necessarily kind of expect to find that. And then kind of these other 2 stable and low misuse groups are at the lower level of cannabis percentage of individuals using daily or almost daily. So this is kind of an interesting initial finding from kind of the individual level rather than the ecologic level, looking at increasing cannabis use in potentially in those who have decreasing opioid misuse. So again, this was just an initial look from the longitudinal data of the sample. We're still kind of running more models. Overall, there's relatively low levels of opioid misuse. I think that's, again, a clear take-home message. The largest latent trajectory group was the stable no misuse group. And the stable no misuse group had the highest percentage of individuals with daily or almost daily cannabis use. The decreasing misuse trajectory had initial increases in percentages of individuals with daily or almost daily cannabis use, just to reiterate the findings. And then, again, some of the limitations here are that it's self-report data, that it's kind of difficult to measure the extent of cannabis use. I think, so this was an R01 where you don't want to change the measure of cannabis use over the time period, because then you would have obviously different measurements at different time points. But there was almost a ceiling effect of cannabis use in some of the measures that we were using to capture cannabis use, and so that creates problems potentially when we're modeling these types of data. The generalizability is obviously an issue, given that these are selected medical cannabis clinics from the southern part of Michigan. So obviously, again, this is the first kind of initial glimpse at these trajectories. Further work is needed to examine this interplay between cannabis use and opioid use in the sample, as well as, we can look at other types of structural equation modeling. One is a dual trajectory model, where we look at both the cannabis trajectories, the latent cannabis trajectories, and the latent opioid trajectories over time. And so that creates these phenotypic groups of individuals who are identified by their both increasing or decreasing cannabis use and increasing or decreasing opioid misuse. We could also think about using cross-lag models, where we're looking at how does your opioid use at one time point relate to your cannabis use at the next time point, holding constant your opioid use at the initial time point, for example. And so those are just some of the kind of future directions that we're thinking about. And one of the other questions is, are there differences between individuals receiving certification for the first time and those who are renewing? Now, and I think the answer is probably yes, but it's very difficult to. There are less people renewing. There are less new initiates of cannabis use as new initiates of medical cannabis certification as time has gone on in Michigan, and that's also been shown to be the case in other populations, other states as well, where the new initiates of medical cannabis haven't risen as steadily as has been projected, especially by the tax revenues and things like that. Okay, for the last project that I'm going to talk about is really in its infancy. It's mostly related to my cannabis IAR and some of the kind of the impetus for why I thought about kind of looking at cannabis use in the primary care setting in the VA. And obviously it's gained a lot of media attention, cannabis use in veterans, as well as it's been a priority for several veterans coalitions, and it's been in grassroots organizations, no pun intended. So like the IAVA, for example, came out with their priorities for this year, and number 6 was to initiate empowerment of veterans who want to utilize cannabis. That's the Iraq and Afghanistan veterans of America, and or association, and so that's something that there's a lot of media and popular press, but not a lot of data behind a lot of this this press. So one of the things when we started the grant was to, went back to the National Survey on Drug Use and Health, because for some reason it was rather low-hanging fruit, but no one had ever done it, was look at cannabis use in the veteran population in the United States, because there's a variable that has that ascertains veteran status in that sample. And this includes both inside and outside of the VA, but I had to start somewhere for kind of the background and motivation for the grant. And so we found that around, and then one of my graduate students was kind enough to write the paper up, so that was great. But 1 in 11 veterans, so around 9%, reported past year cannabis use, which is a little bit lower than the general population, but roughly similar. The kind of one of the more interesting points was that around 41% of those who used in the past year used as for medically recommended purposes by a physician, and so that's the double the percentage of those in the general population, which is kind of interesting. So we thought a little bit more about why that was potentially. And then those who are using non-medically were also kind of more likely to have alcohol use and alcohol use disorder. So this kind of brings me to the current IAR that I'm working on right now, and we're still collecting data. We're just in the initial phases of data collection in this grant. And I wanted to give a little bit more of an overview of the kind of what we're doing in this grant. And so we're randomizing. We have 3 clinics in Michigan that we're going, 3 VA medical centers in Michigan: Battle Creek, which is largely rural, Ann Arbor, which is suburban, and Detroit, which is urban. And we're randomly selecting days that we go to the primary care clinics, randomly selecting the primary care teams that we're surveying from or screening from at those clinics. So we have, in the end, we'll have a more of a representative sample and can know the sampling frame of the from which our patients come from. And so staff are then prepared with the approachable patients for the day. They're given a roster of eligible patients for that day. And so they go to the primary care clinic and screen and approach potentially eligible patients to be screened. So the patient then completes informed consent and takes a brief screening survey and is given a small $5 gift card. And the screening questions are really kind of cannabis use questions, sociodemographic questions, as well as physical and mental health functioning. We also, because this is a veteran population, ask about pain, as well as the PCL, the PTSD checklist, to have kind of a broader understanding of that in this primary care patient group. And then by inclusion criteria, 500 patients with current cannabis use who are using in the past at least monthly are enrolled into a cohort of 500, and then the other patients, because this is a VA grant, we couldn't follow up everyone, obviously, with survey and interviews. But we are able to follow up. What I wanted to say is that what we are able to do with everyone, even though not all of these patients are given the intensive interviews and assessments at 6 and 12 months, we are able to follow them up virtually through administrative data records, and as well as have their pharmacy data, which is kind of something that we're not able to do in other settings, and I think that's a real advantage. So we'll have both comparisons for those who use cannabis and don't use cannabis, but also have comparisons for level of use in these higher cannabis using cohorts, to compare these folks with one another, but also compare them with potentially with these folks as well. So we're thinking about propensity score methods and other methods to kind of balance out baseline characteristics that we are able to collect on those. So I just wanted to briefly, I think because it's my first IR, I'm excited to show the kind of very preliminary findings that we have so far. But we've screened 321 primary care patients, and they're mostly from one VAMC. You can see similar to the medical cannabis clinic, as well as similar to the VA demographics overall. It's mostly middle-aged white males who have a relatively lower level of physical health functioning. 59% have ever used cannabis, and we've also found that 32 or 18% have ever been issued a medical cannabis card. 25 are current. The age at first use was 19. And of those ever using, 65 used in the past year. So around 25 of the 65 have cannabis cards. So that's relatively similar. It's around 38 to 40% of folks have an active medical cannabis card, which is similar to what we found in the National Household Survey. Interesting. Here we show, just to kind of give you a basic frequency of cannabis use in the past 12 months in the screening sample here. We have done baseline, obviously we haven't done any follow-up interviews, but we've also enrolled about 20 people into baseline so far. The folks who are using it every day, nearly every day, 3 to 4 times a week, 1 to 2 times a week, are all eligible for the cohort study. Yeah.
Sorry to.
Yeah, that's fine.
In the middle. But you may have mentioned this, and I probably was attending to something in
Yeah.
my head. What were the aims? Oh, I'm sorry. What were the aims of the merit? You were screening and doing
Yes.
assessments.
So the aims were to really look at the health and functioning in the primary care setting of those who use cannabis and those who don't, as well as to look at, among those who use cannabis, what are their long-term kind of cannabis use patterns and health and function, as well as service utilization, which hasn't been looked at, and I'll get to that in just a moment. But so there have been quite a few studies looking at cannabis use disorder and those who utilize care for cannabis use disorder versus not. But my interest was mainly in does having cannabis use, is that associated with any additional healthcare utilization or less healthcare utilization than similar people without cannabis on board, if that makes sense.
Okay, great, thanks.
Yeah.
That makes sense. So what were the inclusion-exclusion criteria?
So the inclusion criteria were they had to be 18 to 75, be a resident of Michigan, because we also get people who come from Ohio or Indiana, but we wanted the same laws to apply to everyone in our cohort, and then also they had to be using at least monthly. Yeah. So we also asked, we later added perception of risk associated with cannabis use, as well as ease of availability, and this is we wanted to do this just to kind of benchmark it against some NSDUH measures. Around 13% said that so far have said that how much in terms of how much is using once a month in terms of risky. 13% say it's great risk versus 28% in the National Survey on Drug Use and Health, and that's excluding the younger folks in the 12 to 17 and then NSDU. So more people are saying it's not as risky, essentially, in our sample, both using once a month as well as using once or twice a week. And then the ease of getting it is fairly easy according to those in our study, and easier than apparently it is nationally.
What is perception of risk
perception of risk is basically how much do people risk harming themselves physically when they, so this risk question essentially.
They are responding saying there's self-perception.
Yeah, that's right. Like what do you believe, if someone smokes cannabis once a month, do you think that they're physically harming themselves at great risk of harming themselves, at low, it's a Likert scale again, great risk, some risk, moderate risk, essentially no risk. Yeah. Again, there's higher prevalence estimates of past year use than in other national surveys, but the medical use is around the same as the other national surveys. There's lower perceptions of risk in this primary care group, as well as that obtaining cannabis is fairly easy. The limitations are that it is very, very early, but I was just very excited to kind of present some of these early findings with you. So in terms of overall discussion, one of the things that I wanted to kind of talk a little bit more about is it's the fact that it's really critical to think about and test the applicability of some of our existing scales and measures in the medical cannabis population. And I'd just like to highlight this article by Sharon Zinsman and Robin Room called Rethinking Indicators of Problematic Cannabis Use in the Era of Medical Cannabis Legalization. I think really thinking about some of these methodological issues is important, because we oftentimes take for granted of using the same scales in one population versus another, and it may not be appropriate, especially when we're talking about, for example, measure of problematic use of how much time do you spend trying to obtain the drug or obtain cannabis. Well, if you have a medical license, it's not much at all. It's very easy to obtain the drug. Similarly, some of the other criteria that are used in whether or not it's appropriate to use some of these tools in the medical cannabis population is interesting, I think, to think about as well. So I'm happy to talk more about that with you, because I'm curious to hear some of your thoughts as well. So again, this relates back to the IIR question of what kind of a major goal is, and one of the major goals is really to look at health utilization patterns, because in doing the kind of literature review for the grant, there have only really been 2 studies that I found that have looked at health services utilization, the impact of cannabis use on health services utilization. And I'd say the best one was a Kaiser Permanente study from 1993 that looked at 452 members who used cannabis daily and similar members who didn't use cannabis, and found just a slight increased risk of outpatient visits, increased risk of injuries in this population. And there's also been a more recent study out of Boston, but it was a screening sample from a randomized controlled trial, so everyone had at least some sort of drug use, and they were trying to look at whether or not adding cannabis on board was associated with any emergency department or general medical visits, and it wasn't. But it's kind of a different kind of subset of the population, really, than the general medical clinic that I'm kind of focused on in some of the work that we're doing.
Do you know what kinds of injuries are happening commonly?
I'm actually not sure what type of injuries in that study were. I'm not sure if they reported that or not, but that's a good question. I'm not sure if it was accidental or intentional. Yeah. So there are a lot of future directions for research, but some of the ones that I've been thinking about specifically are provider knowledge of medical use. So and the patient-provider relationship. I hope to get at that a little bit in the IAR that I'm working on right now, but a lot of providers, at least anecdotally in our system, don't ask their patients whether they have a medical cannabis card or not, because there are some federal versus state kind of issues. Some do and talk openly with their patients or clients about medical cannabis and how they develop their treatment plan. Depends upon whether they use cannabis or they don't use cannabis. I think another area that's really has been understudied is whether medical cannabis use affects other treatment adherence. And in particular, I've been talking a little bit with folks in the SUD clinic, thinking about opioid use disorder and medication-assisted therapies. Whether or not a lot of the folks have chronic pain and have medical cannabis card. But at the same time, some providers will boot you out of the mat therapy if you're using any sort of cannabis at all, or if you have any drug use at all. And so whether or not that's best for the patient, I think remains to be seen. And then also, what are the treatment outcomes when they're also using cannabis versus when they're individuals who are not using cannabis? And Mallory has done some work on this in the PTSD setting, and is going to do even more work on this with her CDA. So that's really, I think, really great. And then one of the last questions that I'll use is can we intervene in other ways on qualifying conditions that may impact cannabis use and health and functioning? So if some of the things I'm thinking about with Mark Ilgen is if someone is presenting for a chronic pain condition and says, I use medical cannabis for pain, is there a CBT approach for pain that will impact their pain, but also maybe impact their cannabis use as well? So can we decrease their pain and also decrease their reliance on cannabis at the same time? And so some of those kind of links have yet to be tested, but I think is a interesting future direction for research. So at the University of Michigan, obviously, Bo Schembechler was our Hall of Fame football coach, and he always instilled in us the team, and science is the same way. It's always about the team, and so I'm just wanted to acknowledge my collaborators and incredible research and support staff, and these are my grants. So I thank you for your time, and I'm happy to take any questions. I realize we're running short on time because of my coughing fit. I hope, and it's on Monday, so I hope. Yeah.
So Kip, that was great. I have a question for you about, I know there was one slide about opioid, misuse.
Yeah.
Has anybody ever looked at patients with chronic pain who smoke cannabis, and has it been shown that it has an impact on their pain medication use, which is at some point, do they actually use less opioids because somehow their pain is being addressed? I mean, given that most of it is because of pain, and as we talk to our patients, they say it does help them with their pain. That's their perception. But objectively, is there any work done on looking at if it actually has changed the, say, opioid use, not even misuse, but they need lower doses of or lower morphine equivalents of opioids and things like that?
So in the general population, no one has or any clinical settings, none that I'm aware. I mean, there are the clinical trials that have looked at, I think Ziva Cooper and others have looked at with respect to analgesic effects of combining cannabis and opioids, and shown at certain dosages there is an synergistic effect, but at higher doses there may be less so. But in terms of individuals like reducing their opioid use or telling their physician, like, I don't need as much as much opioids anymore. I'm not aware of those studies, and that's kind of where we're trying to go a little bit with the two studies. We'll have some information from the HSR&D IAR on that because we have pharmacy data as well as pain data on those patients. And in the primary care setting in VA, as many of you know, many folks have diagnosed pain conditions.
In the second part of your talk, and it might be the same slide that you were thinking of, Brian, and there's 4 lines, I think, black, red, blue, and green. Do you remember? And you've got the people with the modest misuse, et cetera.
Yeah.
Do we know about other drug use? So, for instance, I was thinking about alcohol, and are people that are not consuming marijuana instead consuming alcohol, or do we have data about that?
Yeah, so we have some data on that in this group that we haven't looked at. But are you speaking to whether or not they're lowering their...
Yeah, it was a pretty striking slide, right?
Yeah,
Because one story you could tell with that is that the use of marijuana reduced their tendency to misuse opioids,
Right.
which would be a very positive outcome.
Right.
But I wondered what else is going on, what else differentiates those groups. I didn't know how big those groups were. I didn't see error bars on it, so I wasn't quite sure how different those groups really were. Can you talk a little bit more and maybe just cycle back to that slide?
So
Yes.
Next one.
this one?
Yes, correct. This one.
Oh, this is the cannabis use one.
This is the slide I would use to argue that cannabis use is harmful to these people.
Yeah, and you're
decreases.
wondering what's the percentages.
I didn't know what the sample sizes
alcohol
were
use.
here. Are the error bars on that? If those differences are really statistically significant.
So the sample sizes for that are essentially, so there's 400 people in this group, and so it's 80% of 400 people, and that. So it's, these two groups are relatively large. This is the smallest group. The black, stable, modest misuse group had around, I think, 60 people in it, something like that. So.
Okay. Is that on the previous slide, the numbers?
Yeah.
Yeah. Okay.
I will say that.
Do you have any? Can you say anything about the significance of those differences? Is that
Not
really?
really. I didn't test that formally yet. I mean, we will be doing that. This is kind of, again, really kind of preliminary data. But yeah, so we will be doing that.
I guess
Go on. Good. Okay.
not as much of a question, but maybe a comment, and I don't know, maybe you've probably put a lot of thought into this, that if in Michigan, the condition that medical marijuana is used for most is chronic pain, and it's not legal to get the card for PTSD or for other conditions, whether your study that's based in Michigan can address some of those questions about the usefulness or the profile or sort of the behavior, I guess, in folks who are using it for other things besides chronic pain. And sort of what are your thoughts about how you could address some of those things? Because I think, I mean, you prefaced your study by saying that, there's this huge emphasis being put on using medical marijuana in veterans, especially for PTSD.
Mm-hmm. We have PTSD is an allowable condition in Michigan.
Oh, fabulous. Yeah. Okay.
It was actually the veterans, and it wasn't initially in 2008 when the initial laws were passed, but veterans were pretty active and got it to our council, and it was then added later.
So, do you have any preliminary data on the sample that you have already? What are the top conditions that they're using it for, and
in the VA one?
Yeah.
We do. I don't know what that is offhand, because that 300 some people that we studied we just kind of grabbed from the database that we're developing right now and kind of ran some analyses. So I didn't grab that out of that, so I apologize for it.
Any other questions? Okay. Thank you very much, first of all, for your presentation. And then you are going to be the proud recipient of a small token of our appreciations for you coming here. UC San Diego School of Medicine, Psychiatry.
Thank you.
We could have VA there, but we probably need federal approval. So, I don't have anything about that, right?
We'll give our own hat, then you'll have 2 hats.
Oh, okay.
There you go. All right.
All right. Thank you very much. I
Thank you.
appreciate it.
That's the model.
Okay. Oh, yeah.
Okay. Oh, that was very good.